We are live now, doctor.
Right. So good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. I am Dr. Vishal Agarwal, Scientific Committee Chairman, Rajasthan Ophthalmological Society. And it gives me immense pleasure to welcome you all for yet another masterclass of the online postgraduate teaching program, Kaksha. Kaksha is a PG teaching program conducted by ROS, which covers all the major topics of the curriculum of PG training in India. We'll be bringing the best of national and state faculty experts to share the knowledge and interact with you freely. The residents who have logged in are also encouraged to put forward their doubts, in a fearless manner. They can interact, they can raise their hand and speak, or they can just, type their queries on the chat box, and we'll be happy to answer them in the class. As usual, there is a small quiz kept at the end of the class with lots of prizes to be won. So keep a strong vigil and stay glued to the class. Coming to this Kaksha, we have today with us Dr. Anusha Venkataraman from Coimbatore to teach us about the most common intraocular tumors which are relevant clinically, of course, as well as which are most frequently asked in your exams. Dr. Anusha is a dear friend since almost 2 decades now, is a prolific VR surgeon, academician, and a teacher par excellence. I I welcome the ROS President Sanjeev Desai sir, President-elect sir, Dr. Virendra Agarwal sir, and our dynamic secretary, Dr. Ghulam Ali, who is our moderator for this evening. Dr. Pooja and Dr. Dashna. Anusha, these two residents are on the hot seat, so you can interact with them informally. Pooja and Dashna, they are all postgraduate students in various institutes in Rajasthan.
Okay.
About a little brief about she did her post-graduation from Delhi, gold medalist from there, and senior resident in the vitreoretinal department from AIIMS Delhi as well. She is working as a consultant for more than 10 years now, and she completed a fellowship from in ocular oncology from Moorfields Eye Hospital, London. Currently, she's working in ASG Vasan Eye Care in Coimbatore. Over to you, Anusha, for your class. Looking forward to it.
Thank you, Vishal. Thank you so much. I would also like to thank Rajasthan Ophthalmic Society for giving me this honor to be here today in the evening. The purpose of the class is to just discuss a few intraocular tumors, the tumors which are of significance for the postgraduates. The idea is just to introduce you to the topics and to stimulate you to read more, because obviously it's a 1-hour class and it's difficult to cover everything in detail. So I will be covering the highlights, the most important points, the most important tumors, and introduce to the not so important ones, and would urge you to read more to gain more information on it. So moving on to this topic, why should you know about intraocular tumors? Why is this topic even relevant? Of course, it's important for your exams. There are certain questions which are asked with respect to melanomas, with respect to retinoblastomas. But the most important thing that is that even if you recognize an intraocular tumor, then saving a hand is in your hands. The earlier you diagnose it, the earlier you detect it, the earlier the treatment is started, and the patient benefits out of it. So what is today's agenda? This is how we'll go about it. We'll discuss in brief about the choroidal tumors, and we'll also touch a little bit on the lesions of the RPE which simulate the choroidal tumors, and also a discussion on the retinal tumors. So without any further ado, we'll jump to the topic directly. Like I said, the first slide was the choroidal tumors, and what we're going to discuss are the melanocytic lesions, or the black or the brown looking lesions in the eye. So what are the common differential diagnoses? When you see a lesion like that, what are the thoughts that would come to your mind? The most common would be a choroidal nevus or malignant melanoma, a disciform scar, which is associated with age-related macular degeneration. We will discuss all these conditions, but this is just to give you an overview. Then chirpy, choroidal hemangiomas, melanocytomas, metastatic carcinomas, and choroidal osteomas. We move on to the nevus. The nevus, we start with the iris nevus. The iris nevus it's a very common occurrence in the whites. You can have, so all these photographs are from patients which were seen during the fellowship. So I've just tried to crystallize whatever we've seen in the last 1.5 years to this 1 hour. This is a diffuse iris nevus. As you can see that there is a flat iris pigmentation on the iris, And an ultrasound biomicroscopy generally helps in distinguishing from a benign nevus from a malignant nevus. In that, when you see on an ultrasound biomicroscopy, you can see that the lesion is flat. There is absolutely no elevation whatsoever, and there's no involvement of the angle. So this is a diffuse benign iris nevus. An iris nevus can also be nodular. So you can see this nodular lesion here at the root of the iris. You can see it's not involving the angle, and even on the UBM, you can see that it is not involving the angle, and it's just an elevated mass. So again, it's a very benign lesion. We'll see how it differs from a malignant lesion. What you need to know here is that if an iris lesion is situated near the angle, a gonioscopy and a UBM is mandatory. So if ever you come across an iris nevus situated at the root of the iris, then you have to do an UBM, because here you can see that it is as opposed to a solid lesion here, which is very suggestive of a nevus. What you can see here is a hyporeflective, or a lesion with a low internal reflectivity, which is suggestive of a malignant process. So here, with a lesion at the root of the iris, a gonioscopy and a UBM is mandatory to rule out ciliary body melanoma. So this is a case of a ciliary body melanoma, which is with also an iris component. So what are the risk factors predictive of a malignant transformation? For easy remembrance, you can have the mnemonic A, B, C, D, E, F. The A is if it's a young age, if there is hyphema in the AC associated with this lesion, if it's an inferior lesion, if it has a diffuse configuration, if there's an ectropion or a distortion of the pupillary margin, or if it has feathery margins. The other features would be a prominent vascularity, the presence of sectoral cataract, the presence of secondary glaucoma, and seeding of angle structures. So that is how you differentiate whether an iris nevus is a malignant or a benign lesion, depending on whether it is solid or it has an low internal reflectivity, and associated with the presence or absence of all these features which I just mentioned. Now, choroidal nevus is also seen in about 7% of the population. It is more commonly seen in the whites, and you can see that the choroidal nevus, as in this picture, is it's a black lesion, and it doesn't really come up on the autofluorescence. It's a flat lesion, and even on the ultrasound, it's a relatively flat, solid lesion. How would you know? Now, this is important. How would you know if a choroidal nevus is becoming a melanoma? So here you can see a photograph, and there is a pigmented lesion here below the inferior arcade. And you can see there are some yellow spots. So these are the drusen, which are seen in a choroidal nevus. However, in the second photograph, you see a lesion, which is again black or melanocytic. And you see these lesions are not yellow, these are actually orange, which are actually the lipofuscin, or the orange pigment, which you see in a choroidal melanoma. So these lesions like this, the presence of orange pigment is very pathognomonic. It signifies a transformation of a benign nevus to a malignant melanoma. The other lesions, the other risk factors which you should know are the TFSOM UHHDD, as described by Dr. Carol Shields. T is a thickness greater than 2 millimeters. S is a presence of subretinal fluid or symptoms. O is a presence of orange pigment, as I've already told you. M is a margin within 3 millimeter of the optic disc. And on ultrasonography, like I said, it would be a lesion with, I would come to that again, it would be a lesion which would have a low to medium internal reflectivity, as opposed to a melanoma, as opposed to a nevus, which would be a solid lesion. There would be an absence of a halo and the absence of drusen. So the halo and drusen are characteristic of a choroidal nevus, whereas the other features are point more towards a choroidal melanoma. So you can remember this small ocular melanoma using helpful hints daily to help distinguish whether the lesion is a choroidal nevus or a choroidal melanoma. So again, we'll just go directly into the topic. We'll discuss choroidal melanoma a little more with detail, because that's important from the exam point of view. What's the etiology of choroidal melanoma? You can see you can have oculodermal melanocytosis, the presence of a white nevus, the presence of a white iris, smoking, and the presence of a choroidal nevus. And environmental factors like exposure to welding or sunlight exposure are more common in males as compared to females, and more common in a white complexion than in blacks. So this is a case one, a 60-year-old male presents with a history of flashes and floaters of 1 month duration with obscuration of visual fields. You see a large mass in the infratemporal quadrant. It is melanotic. The optos does give a little bit of a pseudo color, but it is a melanotic lesion, and this is the ultrasound, which shows the presence of a large dome-shaped lesion. There is surrounding exudative retinal detachment, and there is a medium internal reflectivity And this is another feature, which is a colored Doppler, which shows the presence of internal blood vessels. So this is highly specific for a choroidal melanoma. So the PGs, you can probably be active on the chat box, because there'll be a couple of questions coming up, and you could probably just type in whatever answers you think right. So this is a choroidal melanoma, and then we're going to go to the differentials very soon. So a little bit more about choroidal melanoma. As all of you know, it is the most common primary intraocular tumor in the adults. Sorry for the spelling. The incidence is about 6 to 7 cases per million in the USA. It primarily affects patients in the early 60s, but can have a bimodal distribution. Now, when should you think that an eye has an intraocular tumor or a melanoma? Again, the mnemonic melanoma. M is if the tumor is visible externally. E is if patient experiences photopsia, floaters, or field loss. There is an eccentric visual phenomena because of the presence of retinal detachment. Lens abnormalities such as cataract, astigmatism, coloboma, the efferent pupillary defect caused by secondary retinal detachment. There is no optical correction with spectacles, ocular hypertension, secondary glaucoma, melanocytosis, and asymmetric episcleral vessels, which generally indicate a ciliary body tumor. So the presence of prominent episcleral vessels is also something that you need to look into. So when you have a patient with an intraocular tumor, how do you, or a suspected melanoma, how do you investigate the patient? So the management of choroidal melanoma would include both the investigations as well as the management. So how would you investigate the patient? First is always a clinical examination. The gold standard is an indirect ophthalmoscopy for viewing the tumor, for localizing the tumor, for assessing the extent of the tumor, and also whether or not the retinal detachment is present. So that is the indirect ophthalmoscope. As I previously mentioned, if it's a ciliary body tumor that you're looking at, a gonioscopy and a UBM is very important to look for the presence of angle seeding and the presence of pigmentation in the angle or a tumor spread in the angle, which would alter the management. Now, another important clinical method is the transillumination. As you can see in this picture, the light is either thrown from the opposite quadrant or through the pupil, and the tumor blocks the light, and it transilluminates like this. So in transillumination, you can actually make out the location of the tumor. The other important
Anusha,
investigation when you, sorry.
1 second. I just would like to request you to ask, when you're showing the photographs, you can ask the residents also, and then you can continue with your talk if they can answer
Okay,
that. Okay.
sure. All right. So this is the fundus photography. You can see the relative position of the retinal vessels. I will just show you this slide and then move on to the next for a more interactive discussion. As you can see here, this is important when you're monitoring a choroidal nevus, because this is an image from 2016 and this patient is being followed. When we monitor with respect to the retinal vessels, you can see that this tumor stop shots here, whereas in this picture from 2022, it is actually extended up till here. It's almost come up till this arcade, and even here it is almost reached the apex of this little triangle. So this signifies an enlargement and a transformation of the choroidal nevus to choroidal melanoma. You can see the presence of fluid there on the OCT, which means okay. So yes. So over to the residents now. Can you tell me what this picture shows?
Ma'am, this shows classic double circulation which occurs in choroidal melanoma. Ma'am, we can see the overlying retinal vessels and underlying tumor vasculature also in this.
Yes. So which is the retinal vessel? Can you point out with respect to the arrows, which is the retinal vessel and which is the choroidal vessel?
Ma'am, the retinal vessels are the hyper-reflective ones, more superficial ones with the smaller arrow, and the choroidal
The
vessels are
smaller
behind
arrow.
that. Yes, ma'am.
Yes, so the deeper arrow. So from which condition do you think a fluorescent angiography would be able, suppose you have a mass like what I showed you right now, from which particular condition would a fluorescent angiography help you to distinguish? Like if you have a tumor like that and if you do an angiography, which condition would you want as a differential on an FFA what would you use an FFA to diagnose? I'm not clear. If you have a mass lesion and if you have to do an angiography, what would be the main thing in your mind that you have to differentiate a melanoma from this particular thing? So what lesion would not show any circulation at all? It's a very simple question.
Ma'am, choroidal nevus.
Okay, a choroidal nevus is generally a very flat lesion. Okay, I agree, a choroidal nevus. And any other differential diagnosis that you would consider? I've given you the photograph now. So this is a patient again presenting with an underlying age-related macular degeneration with a dense subretinal hemorrhage. In this case, you can see that the fluorescent angiogram is hardly showing any circulation at all. And this is one condition where you would want to do an angiography to look for the presence of internal, to look for circulation. And this is where the FFA helps. It helps to distinguish between a subretinal hemorrhage and AMD, which is very rarely seen. You can very rarely see bleeds in melanomas, but it can happen when the melanoma has breached the Brooks membrane. So when you have a large mass lesion and you want to know whether it is, when you're doubting if it could be even a subretinal hemorrhage, like especially if it's a macular lesion, then you can do an angiography and it will help you. Okay, so can you tell me the signs on the A scan and the B scan that you see on a choroidal melanoma? The main ones I haven't put on the slide, so that's for you to tell me, and then I will tell you the rest. So what is this ultrasound showing you here? What is this arrow pointing towards?
This is the actually acoustic silent zone, ma'am. That is open.
Acoustic silent. Okay, so what is this sign called?
Ma'am, shadowing, orbital shadowing.
So that is beyond the melanoma, but what is it here? You can see that what happens to the choroid here? So this is the classic choroidal excavation that you see in a choroidal melanoma. Because the melanin does not let the ultrasound pass through, and since the other structures obviously lets it pass and it goes back to the transducer, this area that belongs to the area of melanoma, it gives a false impression that the choroid is actually excavated. So the normal choroid is this choroid, which sends back the ultrasound. But this, because the melanoma is not able to send, so the ultrasound gives a feeling that this choroid is actually displaced more further back, which is not true. But the ultrasound image is such in case of a choroidal melanoma, and this is a characteristic choroidal excavation. So you see the normal choroid starts here, and then there is a dip like this here, and then it comes like this. So this is the classic choroidal excavation that you see in a choroidal melanoma. What is this? What is this called? Anybody?
Is it angle kappa that we talk about in the
Yes. We're talking about an angle kappa here, right? So what leads to the angle kappa? This is the surface of the melanoma. There's a sharp spike at the surface of the melanoma. And again, because the melanoma doesn't let the ultrasound beams through, there's a fall in the spikes of the melanoma. So this angle, this angle, which it forms with the horizontal, is called the angle kappa. So this is the angle kappa and not this. So how do you measure it generally? You draw a line like this, and the angle that it makes to the horizontal is the angle kappa. So it's an acute angle kappa that you see in a choroidal melanoma. What are the other features in a choroidal melanoma? You would see a low to internal echoes. You can see here, it's not, you can see the echoes here. There are very low amplitude spikes, and there are low to medium echoes here. And sometimes you can even see vascular pulsations within the tumor. So, so on A scan, this is what you see, and on a B scan, you get an acoustically silent zone, which is exactly the ultrasound hollowness that we were talking about in the previous slide of how to differentiate between a nevus and a melanoma. It will be acoustically solid in a case of a nevus, whereas it will be acoustically hollow. And this specifically with reference to the choroid is a choroidal excavation, and you can also get shadowing in the orbit. So it has about 95% accuracy for tumors more than 3 millimeters. So you can see here that if the Brooks is intact, you get a dome shaped on the ultrasound, whereas if the Brooks has ruptured, then you get the classic mushroom shaped lesion. So this is just for completion's sake. I mean, you should know if you see an image like this, what I talk about the orange pigment, this is how it looks on an autofluorescent image. You can see all these white spots that appear here are actually the orange pigment, which is very, very, very specific for melanoma. So what is this? Can you tell me? Wait, let me ask you. Yeah. So this is how a melanoma looks like on an MRI. Can you explain the findings on an MRI?
Ma'am, the first image shows a hyper reflectivity, hyper echogenicity.
Hyper intense. Yes.
Yes, ma'am. It is hyper intense. So it is a T1 MRI, and the second image shows hypo intense. So it is T2 image.
Excellent. So the first image, so the melanomas are generally hyperintense on hyperintense on a T1 and a hypointense on a T2 image. And this is same for a subretinal hemorrhage as well. And that is why even if an MRI, if you get something like this, it is important to do a fluorescent angiography to know whether it is a subretinal hemorrhage or if it is just, if it is just a subretinal hemorrhage or a choroidal melanoma. Now this is, you can see here, what is this? I think it's right there. It actually shows an extrascleral extension. Even on the ultrasound, you can see it has breached the sclera. This is a typical collar stud. There is this extension, exudative retinal detachment, and there is an extrascleral component of the melanoma. Okay, so this is exactly what I was trying to tell you. There is the same picture of another gentleman who presented with a mass like this. And the ultrasound and the MRI exactly showed the same picture. It is a hypointense on T2 and it was hyperintense on T1. And the ultrasound showed a very high reflective mass. So this is a very close differential of a melanoma, which you have to keep in mind, especially in the elderly population, especially if the mass is somewhere in the periphery. If it's an irregular mass, if it doesn't really transilluminate as homogeneously as a choroidal melanoma, it could even be an eccentric disciform or a peripheral or a hemorrhage from a peripheral hemorrhagic chorioretinopathy. So that's that. Now we come to this question of, so this is the second case of a 62-year-old gentleman. Okay, just a second. Okay, of a 62-year-old gentleman who presented with some disturbances in a vision for about a 1 month duration. So what are the differentials that come to your mind?
Ma'am, it can be metastasis.
Yes, it can be metastasis. Anything else? So the next slide is basically the differential diagnosis of an amelanotic mass. So whenever you see an amelanotic mass in the fundus, what is it that comes to your mind? As you said, it can be a choroidal metastasis. If it's an amelanotic pinkish looking mass, it could be an hemangioma. It could even be an amelanotic melanoma. Not all melanomas need to be melanotic. It could be an amelanotic melanoma as well. It can be a granuloma. And there could be other conditions like a choroidal detachment or degenerative retinoschisis as well, which I will show you how it presents. So this tumor, incidentally, the one which I showed you, happens to be a melanoma again. There you can see there is a dome-shaped lesion, and on the ultrasound, it is low to medium echogenicity. And what you saw there was actually, again, the orange pigment. So since it's an amelanotic lesion, the orange pigment shows up as, so this is the orange pigment on the autofluorescence. And it actually happened to be an amelanotic melanoma, and the patient underwent a plaque brachytherapy. Okay, so now we move on to the differentials a little bit. So the question again for you, it's a 53-year-old patient who presents with a deteriorating near vision over the last 1 year. What do you do? I'll show you the images and then you can tell me what you saw and how you interpreted it and what's your diagnosis. So this is the image here. Again, I'm sorry, it is the opto, so it's a false pseudo color, but you can see there's a small lesion here and there is this cuff of fluid here. This is the fluorescent angiographic picture. I can come back to it later on if you wish me to. So you have a careful look at this is the early image and this is the late image. And this is the ICG, this is the early image and this is the late image. So what can you make out of this? What differential comes to your mind? So we've listed the differentials. So what differential comes to your mind now? So these are the differentials that we spoke about. So under which condition does, what condition does this fall under? Any guesses? Darshna?
And can it be
So this
a
is the,
choroidal osteoma?
okay. No, it's not a choroidal osteoma. I'll tell you why. This is the OCT image. So it's a choroidal lesion. It is a hump-shaped lesion. You can see these dilated vessels here in the choroid. So that's a clue for you. And this is the ultrasound of the same patient, which shows a very high to medium echogenicity within the lesion. So it's a very high internal reflectivity. So this actually is a choroidal hemangioma. All right. And the images that you saw, the fluorescent angiographic images that you saw, was actually the choroidal hemangioma taking up the lesion right in the very early phases. And then what happens in the late phase is actually a washout. The most specific examination is an ICG, where you can see that the initial blooming or the initial hypersinescence in the early phases. And then there is, as the time passes, there is actually a late washout. So an early hypersinescence followed by a late washout is very characteristic of a choroidal hemangioma. So again, in our ocular oncology clinic, if we have a patient with an amelanotic mass, the patient generally undergoes a fluorescent angiography and an ICG to rule out a choroidal hemangioma as well. So that's that. There is a hyperfluorescence in the initial stages, and as you can see, as the time passes, the hyperfluorescence gradually wanes away. So that's, and these are the, like I said, there are prominent choroidal vessels on the OCT again, which is very specific for a choroidal hemangioma. And a choroidal hemangioma has a very, very high internal reflectivity, obviously because it has got a lot of blood vessels. So the choroidal vessels are all dilated, and it gives rise to what is known as a dancing spiked sign. You see that within the, so it hits the margin of the tumor, but as opposed to choroidal melanoma where there was a sharp downfall, here there is this dancing spike because of the tumor vessels within. And this is again another patient with a choroidal hemangioma. You can see this is the early phases on the FA where it is picked up, and this is on the ICG on the late phase where it is washed out. So, so a little bit about choroidal hemangioma. It can be either diffuse or circumscribed. The one which we have spoken is circumscribed choroidal hemangioma. The onset is between the 2nd and 4 decades of life. And as I said before, it's an orange choroidal mass located at the posterior pole, and it does have associated SRF or subretinal fluid. How to differentiate it from a choroidal melanoma? Obviously, the color, it is more orange or pinkish looking, and there are no intrinsic tumor vessels or feeder vessels that can be sometimes seen in a melanoma. The treatment is asymptomatic. You don't, if the patient is asymptomatic, you can just wait and watch. The other modalities of treatment is laser, or you can do a PDT, or sometimes even a plaque brachytherapy. So I'm not going into too much of detail. The other patient is Sturge, the patient that we see. So this is how it looks like. You can see the choroid is diffusely thickened. This is a diffuse choroidal hemangioma, and you see it in patients with Sturge-Weber syndrome, who also have ipsilateral, you have the nevus flems, and you have the glaucoma. So you have the diffuse choroidal hemangioma. This is the exudative retinal detachment. You can see the entire fundus is sort of pinkish, and the patient, the treatment of choice is again brachytherapy, and this is how the patient behaved after the brachytherapy. So this is the huge tumor before the lesion, and this is how the patient responded after the brachytherapy. So this is again another case for you. A 56-year-old gentleman who complained of some visual disturbances in the right eye for 5 weeks. He has a history of lung adenocarcinoma, which was inadequately treated. Metastasis. All right. So this is a metastasis, and this is how it looks like. Can you identify the typical feature of metastasis on the OCT? You can see it on this OCT. So this is exactly how you would differentiate a metastasis from any other lesion. In a choroidal hemangioma, it was a smooth dome-shaped lesion with prominent choroidal vessels, whereas here is a characteristic in a choroidal metastasis. Can you identify, Gurpreet or Darshna? So it's called the lumpy, bumpy pattern on the OCT. You can see these lumps and bumps on the OCT, and this is very, 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 very typical for a metastasis. Another feature that is there is this the presence of these RP changes over the lesion, which is also called leopard spotting, which is also seen in metastasis. So this is a typical OCT of a patient with a metastasis, and this is the ultrasound. You can see that in the, if you remember, in the choroidal melanoma, it was a more smooth dome-shaped lesion, even the choroidal hemangioma was, but this is a more irregular multi-lobed lesion. And it has a low to medium internal echogenicity. So summing it up all together, a choroidal melanoma, metastasis, and hemangioma. In the presence of the color, it can be a brown lesion or yellow. This could be yellow. This is orange. Location, this hemangioma is generally at the posterior pole. Metastasis, generally multiple. The others are single. The intrinsic vessels are visible predominantly in choroidal melanoma. All the three can be associated with subretinal fluid. In the fluorescent angiography, you can see a hypo in the early phase and a hyper in the late phase. And the same here, whereas in the case of a choroidal hemangioma, it is always hyper throughout. ICG we've discussed. And the most important thing is the ultrasound internal reflectivity. In the choroidal melanoma is generally a low internal reflectivity. In a metastasis is generally a medium internal reflectivity with not a dome shape, whereas a little bumpy appearance. And the other one is a high internal reflectivity. So, so that's that. So am I clear till now? Shall we move ahead? Any doubts so far? Okay, so I take that as a no. And this is how a choroidal osteoma looks like. So this is again another patient who presented with an amelanotic lesion here. And it is actually a benign ossifying tumor with mature bone, which replaces the choroid. So how would you know on an ultrasound whether, I mean, obviously, if you have an amelanotic tumor, you have to do an ultrasound. So what finding would you get on an ultrasound in a choroidal osteoma?
And there will be a hyporeflective shadow present in the choroid.
Yes, because of the calcification, there will be a hyporeflective shadow. So I will come to that, but a brief discussion about choroidal osteomas. They're generally benign bony tumors arising from the juxtapapillary choroid. They're more common in females, unilateral or bilateral, and usually unilateral, can be bilateral in about 20% cases. So like I said, they're generally yellowish or orange. The margins are well defined, but they have pseudopodic margins. You can see these outpouchings here like this, like this, like this. So they're pseudopod margins, and they can slowly enlarge over years. The only complication that you expect is a subretinal neovascularization. So here, what you said exactly, that's what it is here. You see this plate of a bone, which causes a hyporeflectivity, or there is an acoustic shadowing. You see the shadow here. So if it's a osteoma which is just situated close to the optic nerve, what you get typically is a double optic nerve sign. So this is very typical of a choroidal osteoma. You get a double optic nerve sign. This is a normal optic nerve. This is a choroidal osteoma. Because of the calcification, it is giving you another shadow just like the optic nerve. So this is the double optic nerve sign characteristically seen in the case of a choroidal osteoma. So can you tell me what this is? So this is another patient who was referred to our oncology clinic with complaints of a mass lesion which was noted in the left eye. I can give you a clue that the patient had a recent history of trabeculectomy done.
Choroidal effusion.
Yes, exactly. This patient had a choroidal effusion. So you can see there's an encircling choroidal elevation, and there was hardly anything here. It was not only here, but on indirect ophthalmoscopy, it was almost about 360 degrees, and it is a choroidal effusion. Well done. So what is this? So I can give you a clue. This is a 60 or a 70-year-old gentleman who had this particular lesion, which was noticed on incident. It was just an incidental finding when he went for his optical checkup. But again, he was referred to the oncology clinic in suspicion of a melanoma.
Choroidal detachment.
So choroidal effusion and choroidal detachment is more or less the same. So this, you can see the ultrasound. I've also given you the ultrasound there. A bullous retinal choroidal elevation was noted at the temporal equator. So what bullous lesion can you see in an elderly patient in an infratemporal area? It's a retinoschisis. So this patient had a retinoschisis. So like I mentioned in the differential, now we've gone through almost all the differentials. We've seen a choroidal osteoma, how it looks like and how we differentiate. And we also spoke about choroidal detachments and retinoschisis being referred to oncology clinic. So that's this patient. He had retinoschisis, and then the previous one was choroidal detachment. And obviously there's nothing much that you have to do about it. So this is a patient with extrascleral extension. So now that we've covered the differentials, now let's come to a little bit of theory and how we would manage a choroidal melanoma. So what is Zimmerman's hypothesis? Does anybody know what is Zimmerman's hypothesis? Well, that led to the COM study. So we should know what what led to it. So what did Zimmerman hypothesize? Any idea? So Zimmerman thought that he noticed that patients who had enucleation for choroidal melanoma were dying very quickly after the enucleation. And he thought that it is probably the enucleation which is leading to metastasis and death. So the choroidal ocular melanoma study, he came about to find out if this was really true and if there were other modalities of treatment which could be used in patients with choroidal melanoma. So the primary outcome measure was the time to death from all-cause mortality. And the secondary outcome measures were the cancer survival and the metastasis-free survival, disease-free survival. So basically, they just wanted to find out, they randomized the tumors into 3 groups, small, medium, and large, and found and tried to find out if they, I mean, they basically wanted to establish a consensus for treatment. So how did they do it? These were the diameters. I mean, you can go through the book. I think it's there in every book. But then since we will be discussing the management, it is important for you to know that there are small tumors, there are medium tumors, and there are large tumors. The medium tumors are generally 2.5 to 10 millimeters in apical height. This is very, very important from a treatment point of view, because these are the tumors which are ideal candidates for a plaque brachytherapy. The brachytherapy has a penetrance, like you need to deliver the radiation up till the apex of the tumor. So if it's an iodine plaque, you about 10 millimeters, it is the tumor thickness can be about 10 millimeters. Whereas if it is a ruthenium plaque, the tumor thickness can only be about 6 millimeters. So why I'm saying all this is because the medium-sized tumors, you need to know the dimensions, because this is what guides the treatment. And the medium-sized tumors are the tumors which are amenable for plaque brachytherapy. The large tumors, obviously, which is more than this, it is difficult. You have to go in for an enucleation or even a proton beam therapy. I'll come to it in detail, I mean, in short. And the small tumors, which earlier, as per the COM study, they said that we could even observe it, but now people are saying that even the small melanomas can metastasize. So there people are leaning towards early treatment. So coming back to the COM study, it was randomized into 3 arms based on the size of the tumor, small, medium, and large. The small was for observation. The medium was randomized into enucleation and plaque brachytherapy, and the large was randomized into enucleation and pre-enucleation radiotherapy or a proton beam therapy. And the conclusion was that small could be observed, the medium could be treated with plaque, and the large, I mean, both of these did not have, were not inferior. The pre-enucleation radio was not inferior to enucleation, but it had a lot of complications like neovascular glaucoma, the tumor necrosis syndrome. So in large tumors, I mean, it's a patient's choice whether they want to have enucleation done or. So these are the treatment options that I've mentioned. And the prognostic factors, largely the COM study basically suggested that the larger the tumor, the larger the incidence of metastasis. But later on, we also know now that it is not only the size of the tumor, but certain other anatomic factors, like whether or not there is CWD body involvement, whether there is extraocular extension, certain histopathological factors, and genetic factors. So these are these common MCQ questions that we generally in SRship exams and all that. So basically, it is the loss of chromosome 3, the loss of chromosome 1, and the loss of chromosome 9. So basically, it is a chromosome 3 which is most important, and 1 and 9 which are associated with poor prognosis. The good prognosis are where it is a disomy 3, that is, there is no loss of chromosome 3 and a 6p gain. So 6p gain and disomy 3, good prognosis, and 3 monosomy 3 or a deletion of chromosome 3 along with 1p 9q loss is a poor prognosis. So this is just for you to show that there is a melanocyte. It goes to it becomes a nevus because there are some mutations in this GNAC. Then it becomes a class 1 melanoma, which is malignant. And then there is based on the chromosomes loss, it just starts becoming more and more. There is a tendency for increasing metastasis. Now, just for just conclusion's sake, this is the calendar's classification. You know there are different types of melanomas: a spindle A, spindle B, the mixed, and the epithelioid. Now, the epithelioid is the worst, has the worst prognosis because it has a very poor cohesiveness, the tendency to stay together. So obviously, it has a more tendency to metastasize. So these are the different treatment options. So can you tell me, looking at this picture, what treatment for melanoma is being given?
Brachytherapy.
Yes, it is a brachytherapy. So this is an iodine plaque. You see that the tumor is being marked after this is a transilluminator. The tumor is being marked with the transillumination. And then you have the a dummy plaque which is inserted. The position is confirmed. The dummy plaque is removed, and then the original plaque is placed. So this is a plaque brachytherapy, and this is how the plaque looks like. This is the iodine plaque, and this is a ruthenium plaque. The complications are, this is theoretical. It can cause because it's radiation, all features of radiation retinopathy like optic neuropathy, maculopathy, cataract, neovascular glaucoma. So this is another patient of ours who was treated with a ciliary body melanoma. You can see this huge melanoma, and this is how the patient behaved after the plaque brachytherapy, just to show how effective the plaque is. What is more effective is a proton beam. So in what cases would you do a proton beam? So it is very, very, it's just common sense. Basically, the areas where you cannot put a plaque. So basically, very posteriorly situated tumors where you cannot insinuate the plaque onto the scleral bed, like deep below, or where tumors which are very close to the optic nerve head, or tumors which have been treated with brachytherapy and have relapsed and they go on for a proton beam. So in the management of choroidal melanoma, you just need to know these few indications as far as postgraduates are concerned. And you can see this is a juxtapapillary choroidal melanoma. You can see the orange pigment here, which is very suspicious. There's a scuff of fluid here. So it's definitely a juxtapapillary choroidal melanoma. And like I said, these are the indications: tumors close, brachytherapy, and of course, larger tumors. Like I said, the medium-sized tumors are favorable for brachy. The larger tumors go in for a proton beam. A proton beam is more effective. It's about 95% more effective, but it's slightly higher complications like radiation associated complications. And what generally is done for a proton beam is these are these markers, what we know as the tantalum markers. This is the transillumination being done again. This is another, not this eye, but another eye. You can see the melanoma here. And this is a large tumor. So the patient has been given these tantalum markers, and this is how the patient undergoes a proton beam therapy. Now, enucleation, of course, for larger tumors, you have to enucleate. And what is more important here is for all patients with choroidal melanoma, a metastatic evaluation is important. A physical examination with emphasis on the bone and soft tissue examination. So you have chest X-ray, complete liver tests, and also the MRI, which is important. So TTT can also be done for smaller tumors. I'm not going to the detail. You can just remember that for small tumors not involving the optic disc, the TTT is also an option. And a stereotactic radiotherapy where the patient is made to lie down with a head and with a helmet, and then three-dimensionally the tumor is positioned, and this is basically using gamma knife. So this is another very, very close differential. So now we move on. So that is all about choroidal melanoma. All right, we've discussed the features, the clinical features, the differentials in brief. We will discuss more differentials, and we have discussed the management in brief. Now, this is a very, very close differential of melanoma, which is also known as an optic disc melanocytoma. Okay, so how do you differentiate a melanocytoma from a melanoma? It's very clear from the picture. You can just look at the picture and tell me how to differentiate. Anybody? So you can see this tumor here. Yes, Darshana, you want to say something?
Ma'am, the lipofuscin pigmentation is less in this.
Is absent in this, in melanocytoma.
Is absent
okay.
in this, yes.
Yes, okay, agreed. Anything else? The way it looks. The way it looks.
Anusha, you can check the chat box also. There are some answers that it's a pre-retinal location.
I'm sorry, I'm not able to see the chat box. Okay, let me check. Okay, so basically, yes, I think I can see it now. Yes, so basically, yes, it is a pre-retinal location, and it comes onto the optic nerve. Whereas you can see that in the lesion above, it is not coming onto the optic nerve, right? It is what's happening here? It is staying a little above the optic nerve. So the margins are not involving the optic nerve, but they are. So here it is coming onto the optic nerve. You can see that it is abutting onto the margins of the optic nerve, and it is basically got feathery margins because of the extension into the retinal nerve fiber layer. It has got a very, very rare chance of malignant transformation, whereas you can see in this picture that the lesions are. Just give me 1 minute. I have to not able to see the slides clearly. Okay, so in this, you can see that the images, the lesion is just above the optic nerve, and it is the margins of the optic disc is very, very clear. It's not abutting onto the optic nerve. Very rarely there can be a juxtapapillary melanoma, which is huge, it breaches the Brooks membrane and comes on to the optic nerve. But in such cases, you will also see the other features that we just discussed, like there'll be vascularity, there'll be a lot of the ultrasound will show that it is very acoustically hollow, whereas in a melanoma it will be acoustically dense. So this is how an optic disc melanocytoma looks like. You can see these feathery extensions into the nerve fiber layer and very, very rare chance of malignant transformation. Now, which of these three, you see this one and this one and this one. So you see a patient with all these three lesions. Which of the three lesions do you think is associated with familial adenomatous polyposis? Because I've seen a lot of residents come to me and say, ma'am, this patient has got chirpy. So this is basically chirpy or a congenital hypertrophy of the retinal pigment epithelium. But which of these three lesions are actually associated with FAP and need an evaluation by a gastro person? Not all of them need. So which one of the three do you think needs an evaluation?
Second one.
Barefoot appearance.
Okay, so the bear track appearance. All right. So that is what we initially used to think. But bear track also is a form of a typical chirpy, which is called a group pigmentation of the retina. The bear tracks are also not really associated with FAP. The ones which are associated with the FAP is the third one, this one, which is, it is an atypical chirpy. These both, the first one and the second one, are typical chirpies. This is a solitary chirpy. This is a grouped chirpy. And here you can see the bear tracks. And here, okay. So what you said is partially correct, because if the bear tracks are there in multiple quadrants, then no, this is just unifocal. But if you have multifocal bear tracks, yes, the patient could have FAP. But here, since it is just in one quadrant, it is innocuous. And this is the third one, which is associated with FAP. And this is the atypical one. So you see that the lesions are a little bit oval or pisiform elongated, and they have this halo around it. Even the classical chirpy, you have what you can see is you have a halo around the lesion, and you have some certain areas of choroidal atrophy, also known as lacunae. So those are very typical for a solitary chirpy. So this is again a differential diagnosis for melanoma. Many patients are referred with this lesion, but it turns out just to be a chirpy, and there's nothing really that we have to do about it. So atypical chirpy is associated with FAP. It can be a Gardner syndrome or a Turcotte syndrome, again, just for academic purpose. Gardner syndrome is where it is associated with skeletal hematomas and various soft tissue tumors, and Turcotte, where you have FAP with various brain tumors. So soft tissue skeletal is Gardner and brain is Turcotte. All right. So this is another lesion which is called the chirpy. It is again, it is a congenital hematoma of the retina and retinal pigment epithelium. It's not a very rare lesion. We do see it in our clinics. The patient comes with a pigmented mass, but what you also see is you can see these. This is an epiretinal membrane. There are striations. The vessels have become tortuous because they have been pulled. So this is basically a gliotic lesion. Okay. So this is a chirpy. Again, patient is either asymptomatic, and all what we require is just conservative. All right. So next, so this is all about the choroidal tumors and about the differential diagnosis. We've covered the amelanotic lesions, hemangiomas, choroidal osteomas, choroidal tumors, metastatic tumors, and also the RPE tumors, which simulate choroidal thing like a chirpy and a combined hematoma, and also other like very benign lesions like retinal detachment and choroidal detachment, eccentric disciform. We've covered everything. So this is all about the choroidal tumors. We move on to the retinal tumors now. So this is a very, 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 very common situation in India because the incidence of this tumor is very high. And the parents notice a child with a 2 months old, and this is what the parents have noticed. So, so yes. So what is it? What was, okay. Okay. So what do you think about this lesion?
Anusha, your screen is not visible. You are visible now.
Yes. Sorry, I think I don't know, something just happened. Is it okay
Yeah,
now?
now it has started sharing audio. Yeah, now it is visible. You can make it full screen.
Okay. Okay, sorry about that. Okay, so what do you think about this? It's a two-month-old child. What are the differentials? I mean, there are a lot of people, right? Yes. Yes, Pooja.
Cataract,
Cataract. Okay, that's one differential.
persistent vitreous,
What is the most common thing that you would see in what is the most what is it that should come to your mind immediately when you see a child with a white reflex or a leukocoria? Yes, yes, we're dealing with intraocular tumors. So the most common thing is an retinoblastoma, right? So what are the differentials of retinoblastoma? So retinoblastoma, okay. Somebody said congenital cataract, okay. More differentials.
PHPV.
Coats disease, yes. Coats.
Advanced
PHPV.
stage of ROP.
Very good. Advanced stage of ROP.
Persistent hyperplastic primary vitreous.
Persistent hyperplastic
Toxocara
primary vitreous.
endophthalmitis.
Very good. Toxocara endophthalmitis. Very good. So I think it is covered almost, you've covered almost everything. You can remember it with the mnemonic PREDICT. P stands for PHPV or a persistent hyperplastic primary vitreous, where the I will be microphthalmic. The I is not microphthalmic here. R is retinoblastoma, or like somebody said, advanced ROP. Another important feature, another important differential is retinal astrocytoma. Then E is endophthalmitis. Like you said, it can be traumatic or even a toxocara endophthalmitis. D is for dysplasia of the retina. I is an inflammatory cyclitic membrane like uveitis. C is congenital cataract or Coats disease, or sometimes even a large coloboma which gives you this white reflex. And T is for toxocariasis. So you can use this mnemonic PREDICT to remember the differentials of leukocoria, which is a common theoretical question, viva question, everything. So this is what the differentials would be. Okay, so we a little bit about retinoblastoma now. It is the most common primary intraocular tumor, and it is basically caused because of it is basically caused because of a loss of function of the tumor suppressor RB1 on the long arm of chromosome 13. Again, academic interest. The frequency ranges from 1 in 14,000 to 1 in 20,000 live births, but in India is slightly high. And the most common presenting features is leukocoria, strabismus, and the other features can be ocular inflammation, heterochromia, hyphema, cellulitis, cataract, glaucoma. So basically a child who comes with a red reflex, or a young child or a young baby who has strabismus or any features of ocular inflammation, or a differently colored iris, or hypopyon, or cellulitis, or ophthalmos, or cataract, any abnormality, you have to rule out retinoblastoma. Okay, so now again, this is important. It is an important topic. It's slightly confusing. I'll try to make it simple. The genetics of retinoblastoma. What do you think is, how is the inheritance of retinoblastoma? Is it autosomal dominant or autosomal recessive? What is the Knutson's two-hit hypothesis? So that will give you the answer, right? The Knutson's two-hit hypothesis states that the tumor requires inactivation of both the alleles of, so there are two alleles to the retinoblastoma gene, and it requires an inactivation of both the alleles. So basically it is autosomal recessive. But when the retinoblastoma is transmitted, so for example, if I'm a carrier and if I have a retinoblastoma mutated gene in my system, it will pass on to my child. So the cancer predisposition is autosomal dominant. So even if the child has one RB defective, one retinoblastoma allele, he has an increased predisposition to develop cancer. So it is also autosomal dominant. Whereas if the tumor manifestation of the tumor itself requires an activation of both the alleles. So it is autosomal recessive. Now, generally about 60 to 70% are unilateral. The mean age at diagnosis is about 2 years, and it is non-heritable. Means it is not. It does not have the tendency to pass on to the next generation. So here, what happens is the individuals are born with two normal copies, and both the copies get mutated in the retinal cells in early childhood, and they are not at risk of passing these gene mutations to their children. So that is about 60 to 70%. The other 30 to 40% are bilateral, which means they're diagnosed early at about 14 months, and they're heritable, means that they can be transferred on to the next generation. What is interesting here is that even though most of the patients have, if you can listen, just pay attention to this point, even though the patients who have hereditary retinoblastoma, they could inherit an altered copy from one parent. It could happen, the new mutation could happen in the egg or the sperm or soon after fertilization. So only about 7 to 10% of retinoblastoma have a positive family history. So if there's a father with retinoblastoma, it is very unlikely that the child has to have retinoblastoma. Or if the child has retinoblastoma, it is very unlikely that the father also has retinoblastoma, because the bilateral retinoblastoma, because the mutation could have even occurred after fertilization. So about 30% of children have a new germinal mutation, and only about 7 to 10% have a positive family history. 85% of heritable retinoblastomas are generally bilateral, but you can have unilateral retinoblastomas also, which have a germline mutation. So the heritable ones are called germline mutation, which are generally bilateral, and the ones which are non-heritable are generally the sporadic ones, which are unilateral. So this is just for completion's sake. If the parent has bilateral retinoblastoma, the chance of an offspring having retinoblastoma is about 45%. If the parent had unilateral retinoblastoma, the chance of an offspring having retinoblastoma is about only 77 to 15%. So now we will go on to the classification of retinoblastoma. The classification of retinoblastoma, all what we know is the one thing that comes is the Rees-Ellsworth. But the Rees-Ellsworth was in 1960s because it used to predict the chances of saving the eye following external beam radiotherapy. So external beam radiotherapy is where the radiation is given from outside. And the problem with external beam is it caused a lot of issues with bilateral retinoblastomas. It led to the formation of intracranial tumors and sometimes even like pinealoblastomas. And also it caused orbital contraction syndromes. So now external beam radiotherapy is no longer used, and Rees-Ellsworth, so is Rees-Ellsworth classification. What we now follow is the International Retinoblastoma Staging System. You can find it in any book. It just depends on whether depends on the extent of the disease, whether it is just within the eye, and whether it has been completely resected, whether there's regional extension, or if there is metastatic disease. What we now follow again for the management is the International Classification of Retinoblastoma, or the ICRB classification, and this is how it looks like. So this is a small, so you have a group A, group B, group C, group D, and group E, and that's how we will discuss the management. All right. So the group A tumor is a small tumor which is confined to the equator. Okay. So how do you think you can treat this tumor?
Ma'am,
Anybody?
laser photocoagulation.
Absolutely. So this is a lesion far away, situated far away from the center of the eye. So obviously it is amenable either to laser photocoagulation, or if it's a more peripheral tumor, you can do a cryotherapy. But this is a group B tumor, which is right there on the macula, and it's a slightly larger tumor. So can you do a laser or a cryo?
No.
No,
No.
ma'am,
No. So what will you do here?
we should go for intra-arterial chemotherapy, ma'am.
Okay, so again, we'll come to the details of that. It's a good answer. We can either go an intra-arterial if it's a unilateral retinoblastoma. Germline mutations, if it is a bilateral, we go for an intravenous chemotherapy. So this is a group B retinoblastoma. This is a group C retinoblastoma. You can see that there's a huge tumor, and these small white dots, arrows, what are these? These are actually seeds. Subretinal seeds which are separated from the tumor, and there are some small seeds overlying the tumor as well. So this is a foveal tumor, but it is still confined to the retina, and this is a larger tumor. It's a group C. So again, we go back. A small tumor is group A, which is less than 3 millimeters in basal diameter or thickness. B is beside the macula or optic nerve. So A, B, C, D, E. Okay, B is a bigger tumor. C is contiguous seeds. D is diffuse seeds. E is extensive tumor. So C we've already seen. It is just so retinoblastoma is a bigger tumor, more than 3 millimeters, and it is situated close to the optic margin or the fovea. Contiguous seeds, again, it is less than 3 millimeters, but it has subretinal and vitreous seeds, which are very closely situated to the tumor. Now we move on to the group D. So this is group D. You can see there's a tumor, but there are diffuse vitreous seeds. Diffuse vitreous seeds. And then this is group E, which is a large tumor, touching the crystalline lens. So this is causing neovascular glaucoma, ophthalmos, orbital cellulitis, and all that. So that is a group E, which is basically an advanced retinoblastoma. So I think you yourself have given the management options here. The group A, which is a small focal retinoblastoma, is amenable to either laser or cryo. Well said. The second one, a group B, if it is a unilateral retinoblastoma, yes, you can go in for an IAC. The same applies to a group C. You can go in for an IAC. If it's a germline retinoblastoma, a germline means a bilateral or a hereditary or the one which has been herited, which has both, which is a genetic mutation in the in the germ cells, in the germ lines. So this is the group D. So group D, what do you think can be the management? We're anyway going to discuss it. So even if it's wrong, it's okay. What do you think can be the management for group D?
Intravitreal chemotherapy can be combined with
Yes, very, very good.
intra-arterial or
Intravitreal.
intravenous.
Exactly. So because there is presence of diffuse vitreous seeds, you can combine intravitreal. You have to, in fact, combine intravitreal chemotherapy along with intra-arterial or intravenous, depending on whether it is unilateral or bilateral. And this is obviously a groupie which is very advanced. So what would you do here? You really wouldn't want to take any chances, would you? Because the patient has a high risk of developing metastasis. So here what you would do is enucleate the eye. So evaluation, I will go directly to the retinoblastoma ultrasound. What do you see here? What is a typical ultrasonographic feature of retinoblastoma? You will see. You can see something here on the ultrasound.
Ma'am, hyperreflectivity due to the calcification.
Yes, hyperreflectivity due to the calcification. So this is what it is here. You can see calcifications, and sometimes there can even be, it may not be a homogeneous lesion, it could be a heterogeneous lesion because of necrosis and hemorrhage. And sometimes you can see something in the vitreous also if the patient has vitreous seeds or hemorrhage. So now this is something which is like a spotter, which you have to tell me. The MRI in retinoblastoma. Okay, so retinoblastoma, I will tell you how it looks. So on T1 and T2, it looks, it's basically how a melanoma looked. It is hypo-intense on T2 and a slightly hyper-intense or iso-intense on T1. This is a fat suppression image. You can see it's becoming more prominent. So this is an MRI. So why do we need to do an MRI in retinoblastoma? It is mandatory to do an MRI in retinoblastoma. Can anybody give me some reasons as to why we should do an MRI in retinoblastoma? The answer is in the image below.
Ma'am, to see the optic nerve involvement, post-laminar involvement.
Okay, good.
Extension of the tumor.
Extension of the tumor, correct. Yes. What do these three depict? Anything that comes to your mind? The pattern of the tumor here, here, and here. It basically shows whether the tumor is endophytic. This is exophytic, whether it is a diffusely infiltrating retinoblastoma or if it is an endophytic tumor. An exophytic tumor is the one which grows into the vitreous cavity. An endophytic tumor is which grows towards the orbit. So basically, when it goes into the vitreous cavity, what will you get more? You will get an intraocular mass, you will get vitreous seeds. Whereas if it is an endophytic lesion, it will go behind the retina, towards the choroid, towards the sclera. So there is larger chances of dissemination and retinal detachment, exudative retinal detachment. And a diffusely infiltrating retinoblastoma this is how it looks like. It's a very important differential when you see a patient with Coats disease. What you have to differentiate is you have to differentiate a patient with Coats disease from a diffusely infiltrating retinoblastoma, because both of them will have exudative retinal detachments. But in a diffusely infiltrating retinoblastoma, you see that the retina will be thickened as opposed to the Coats, where the retina will not be thickened. Also, in a Coats disease, you will have a yellowish glow, whereas in retinoblastoma, you will have a more of whitish glow. And in retinoblastoma, you will have vessels, intrinsic vessels dipping into the tumor, whereas in Coats disease, you will have more of a telangiectatic network over the surface of the retina. So these are the three features which differentiate Coats from a diffusely infiltrating retinoblastoma. And the other differentials we've discussed, a PHPV, it will be microophthalmic. Retinopathy of prematurity, you'll have a history of prematurity. Toxocara, you will have a history of pica and you'll have signs of inflammation. The others, congenital cataract, obviously, it's something that you can make out on clinical examination. So basically, this is the MRI which shows the type of retinoblastoma. This is the exophytic into the vitreous cavity. This is a diffusely infiltrating, and this is an endophytic retinoblastoma which is growing outwards. Now, this, like somebody mentioned, it is also used to show the extension. So what can you see here?
Optic
yes,
nerve
optic nerve involvement. Yes,
Invasion.
optic nerve involvement. Yes, this is an optic nerve invasion. And here, can you make out anything? So this is the tumor, and you can see this is a choroid. So this is choroidal invasion. Okay, and this is basically anterior segment involvement. Can you see this here? The hyperreflectivity here, it is basically anterior segment involvement. And what is this? spotter?
Pinealoblastoma.
Very good. This is a trilateral retinoblastoma where there's an ectopic. So you can see the retinoblastoma in both the eyes. This is the T2 image. You can see the retinoblastoma here, and you have a lesion in the pineal gland. So this is a trilateral retinoblastoma, and this is also picked up on the MRI. It is seen in only about 2 to 5 patients with germline mutations, but the sad story here is that the median survival is only about 8 months, irrespective of what you do. And the patients with germline mutations, basically all patients who have bilateral retinoblastoma, a unilateral multifocal retinoblastoma means presence in multiple quadrants. A unilateral retinoblastoma with a family history should all undergo serial imaging of the CNS to look for pinealoblastomas. So other uses of MRI is basically to monitor the response to treatment, to detect recurrence, and obviously to differentiate from simulating lesions, which we've already discussed. So investigation of a retinoblastoma, basically we've discussed the differentials, we've discussed the clinical features, the different grouping, the characteristics. We've discussed the investigations in terms of ultrasound and how MRI helps us. So now we move on to the treatment of retinoblastoma. I think most of this you've already covered, so there's not much for me to cover. But just for completion's sake, I'll just lightly touch upon it. You have intravenous chemotherapy, intraarterial chemotherapy, intraocular chemotherapy. So either systemic, directly into the artery or into the eye. Then focal consolidative chemotherapies, focal therapies like cryotherapy, TTT, or a plaque brachytherapy. Then you have enucleation, and then you have external beam radiation, which is not really in vogue these days. So this is a very nice treatment algorithm, which I found in the Indian Journal of Ophthalmology in the November 2020 edition by Shields et al. On the modern treatment of retinoblastoma, which basically summarizes what you need to do. So if the retinoblastoma is unilateral, if it is an A, like Dakshina mentioned, you can do a cryo or a TTT. If it's a macular sparing group B, you can again do a cryo or TTT, but if it involves the macula, you have to go for an intra-arterial chemotherapy. The same applies for group C, D, and E. You can go for an intra-arterial, but generally, what is the risk with intra-arterial chemotherapy? Sometimes what happens in group D and group E, the patient has micro, like choroidal invasion, and which can develop systemic metastasis. So suppose you have high risk features, and that's why the MRI is again important. If you have high risk features like choroidal invasion or an anterior segment invasion or an optic nerve invasion, you would generally not go in for an intra-arterial chemotherapy, because the patient, what you're treating is only within the eye, but the patient has already a risk for developing a systemic metastasis. So in such cases, you would actually prefer an intravenous chemotherapy, even if it is a unilateral retinoblastoma. So if there are high risks on the MRI, like choroidal invasion or an extraocular extension or an optic nerve invasion, you would generally want to go in for an intravenous chemotherapy, even if it is unilateral. Bilateral, there is no doubt about it, germline mutation, because the patient also has a tendency to develop other secondary tumors. So that is also like sort of mobbed up. The oligometastasis, what they say, that is a micrometastasis, is also mobbed up when you give these intravenous chemotherapy. And also basically, since there is a probability of developing, suppose it's a unilateral, but still you know that the patient has a germline mutation if you do the genetic study, and there is a tendency for the child, or if it's a very small child, then you know that it is a germline mutation, because unilateral are generally detected by about 4 years. Bilateral generally present within the first 1 year or 2 years. So if it's a young child, you will not want to err. You would want to think in terms of a germline mutation and give intravenous chemotherapy. Then what happens is you do every 4 weeks, you just image the child. If there's an improvement or stability, you can do a consolidation therapy. If there is a failure to the treatment, an IAC or IVC, that's when you think of doing something else. So for example, if the patient hasn't been treated with IVC, and if there is a recurrence or if there's a solid tumor which you can see, you can do an intra-arterial chemotherapy or even a plaque. Just put a plaque at the area of where the tumor is. And like again somebody mentioned, if there are vitreous seeds, you can complement the intravenous chemotherapy with, or the intra-arterial with an vitreal chemotherapy. And if there's an intracameral seeds, you can give intracameral chemotherapy. Again, if there is high suspicion, you really don't want to make any chance. You don't want to take any chances. If there are high suspicion, or if there are documented high risk factors, then you have to go for enucleation. And then based on the histopathology, decide if the patient needs an adjuvant chemotherapy as well. So that's about the management of retinoblastoma in brief. You can read more, so I think it'll become more clearer, but that's a simplified form of it. So this is how you can see there's a small retinoblastoma here, and the patient has been treated with focal therapy, and the patient is doing well, and the retinoblastoma has regressed. The intravenous chemotherapy, just a little bit more about it. There are 3 drugs. There is vincristine, etoposide, and carboplatin. Where do you use intravenous chemotherapy? We've already discussed this. Wherever you have a suspicion of a germline mutation, or if it's a bilateral disease. So if it's a bilateral disease, a confirmed germline mutation, or a family history of retinoblastoma, again, I said if there are unilateral cases, but again, if you have suspected optic nerve or choroidal invasion, and sometimes if the child is too small, less than 6 kgs, and if you're still planning an intra-arterial, but the veins would be too fragile, you would not be able to cannulate them. So for till the time the patient is eligible for an intra-arterial, you treat the patient with intravenous, which is called a bridge therapy. And sometimes, I've already mentioned this, you can give it after enucleation if there are high risk histopathological features. So this is another question. What are the high risk histopathological features in retinoblastoma? 1 is the presence of a post-laminar optic nerve invasion. 2 is a choroidal invasion more than 3 millimeters. And 3 is an extraocular extension. So this is another patient who was treated at our clinic who had a group B retinoblastoma in one eye. And you can see there how well it has regressed after all the 6 cycles of intravenous chemotherapy. And this is another patient who had a group D unilateral. And this is how it has regressed very well. There are calcified tumor as well as some calcified seeds around it. Intra-arterial chemotherapy, again, we've discussed. It is primarily for non-germline tumors, unilateral, group B, C, D, or E, and it can be a secondary therapy for recalcitrant disease, and also it is effective against subretinal vitreous seeds. What are the drugs used? So the drugs used in intravenous chemotherapy are VEC, or the vincristine, etoposide, and carboplatin. The drugs used for intra-arterial are melphalan and topotecan. And how do we do it? Like, this is what I said, patient selection is critical. If there is optic nerve or massive choroidal invasion, it can lead to metastasis if the patients are managed only with IAC. Now, this is how the intra-arterial chemotherapy is done. Basically, cannulate the internal carotid artery. From the internal carotid artery, you go to the ophthalmic artery, and then there's a small balloon which is inflated prior to the injection so that there is no retrograde passage of the drugs, and then it is selectively given into the ophthalmic artery. Sounds simple, but it's very tricky, and it has to be delivered accurately, and it can be associated with complications like retinal venous occlusions or vein occlusions if not delivered properly. So this is a patient again with group B, did very well post IAC. This is a patient with group D, again did very well post IAC. So what are the most common secondary cancers associated with retinoblastomas? So you know that a patient with bilateral retinoblastomas can have secondary tumors, right? So which is the most common secondary tumor that you can see in a patient with retinoblastomas? Secondary cancer. You can see pinelomas. The answer is missing here. You can see cutaneous melanomas. You can see soft tissue sarcomas. But which is the most common secondary cancer? Anybody?
The chat box says cutaneous, but
No, I'm sorry, it's not
CNS
cutaneous.
tumor.
No. So pinelomas are CNS tumors, but it is there. I mean, I said the answer is missing from here. I have not given the answer here. So it is not cutaneous melanomas. It is all these can be seen. You can see pinelomas. You can see cutaneous melanomas. Yes, bone tumors. So the most common is an osteosarcoma. So most common secondary tumor is an osteosarcoma. So generally we think of RB, okay, bilateral, okay, pinealoblastomas. But the most common secondary tumor is actually an osteosarcoma. Another tumor which I can show you here looks like an medullary. So this is one child we had in our clinic. We thought it was retinoblastoma, presents with a large lesion, exudative retinal detachment. We thought endophytic retinoblastoma, large lesion, group E, and enucleation. But this was the ultrasound scan. You can see a lot of cavities here, and you can see calcifications also. So this is a lesion called a medulloepithelioma, which generally arises from the ciliary body, can be intraocular, and can simulate a retinoblastoma. So that is one differential. So that is again generally arising from the ciliary body. You can see the ciliary body cysts. Okay, so we don't go too much into it now. So again, so now we're coming into, so we spoke about the The retinal, the retinal tumors associated with the retinocytes. So we spoke about retinoblastoma. Now, what is left? We need to speak about the ones which are associated with the retinal glial cells, with the retinal vascularity, and also with the retinal lymphocytes. So now we finished retinoblastoma. Now this is, you have to spot this condition for me. The history is that of a 25-year-old female who presents with exudation like this, as you can see in the picture. And the ultrasound detects a small nodular lesion. I have posted the ultrasound picture also. It's a small nodular lesion which you can see. Any guesses?
Retinal capillary hemangioma.
It does not have any, you can see it does not have any feeder vessel here. A retinal capillary hemangioma will have feeder vessel. Sorry?
Retinal artery macroaneurysm.
Retinal artery macroaneurysm, generally you would see it more at the posterior pole, which will cause exudates like that. This is a lesion which is most commonly seen in young females, looks like Coats disease, usually seen in the infratemporal periphery, can be sporadic or can be associated with conditions like retinitis pigmentosa, uveitis, etc. You can see a small nodular lesion here on the ultrasound.
So retinocytoma.
Okay, a retinocytoma is actually a regressed retinoblastoma, and a tumor which is not developed into a retinoblastoma. It will not cause any exudation as this. So this is something leaky, right? It is called exudation. It's causing exudation all around. So this is a vasoproliferative tumor. Okay, the vasoproliferative tumor can be isolated. Why I said this, why I brought this to attention is because sometimes when you get this or something like this, I'll show you the next slide, then you will be more something like this. Okay, so this is one patient whom we had in our clinic who presented like this. She was a young female and she was about 89 born, so she must be like 26 years old, and she had this huge Coats-like presentation. But when we did an ultrasound, this ultrasound is actually hers. We found a small nodular lesion in the infratemporal periphery, and we put a nice plaque over it in the periphery, and you can see how well it has regressed. So this is actually a vasoproliferative tumor, which is more common in females, whereas Coats, you will see it's more prominent in young males, right, where you have telangiectatic vessels and all. So this is just a nodular lesion in the periphery. It can be isolated or it can be associated with retinitis pigmentosa, most commonly sickle cell retinopathy, long-standing retinal detachment, uveitis. And like I mentioned, you can either do a laser or you can do a cryo, or if it's a larger lesion, you can do a brachytherapy. So this is just put the plaque over where the lesion is and it regresses beautifully. So this is one such patient we had in our clinic. This is pre and post brachytherapy. All right. Now this is another spotter. This is an easy one.
Retinal astrocytoma.
Yes, it is a retinal astrocytoma. This is there over the disc, but you can even see this away, like you can see it anywhere in the retina, but they're typically mulberry-shaped lesions. Okay, and this is a very close differential of retinoblastoma. Somebody did say astrocytoma when we were discussing the differentials of leukocoria. So this is how an astrocytoma looks like. You have these, it may be multiple, it may be single, it may be unilateral, maybe bilateral. And what you see on the OCT is a characteristic. You can see you have these hyper-reflective borders and you have hypo-reflective echos within it. So this is called a typical moth-eaten appearance, which you see in this condition. So where do you see this? So what would you do if you see this condition? What is required now?
NF
what else do you
screening.
need to look for? NF. More than NF? Which condition is astrocytoma associated with? Okay, so the diagnosis is astrocytoma. Sorry?
Tuberous sclerosis.
Yes. So the association is tuberous sclerosis. So you need to look for other ash leaf, all that spots on the body. It can be associated with retinitis pigmentosa, can be seen in neurofibromatosis as well. Why it's important is because when you have these lesions elsewhere, not on the disc, but elsewhere on the vessel or anywhere, it can be confused as retinoblastoma, but it is a solitary lesion. It is a non-progressive lesion. It doesn't have any intrinsic vessels and it doesn't have any calcification. It can be seen, the differentials can be a angioblastoma, a melanotic uveal melanoma, or choroidal metastasis. So the treatment is basically nothing, just do a systemic evaluation. And as far as the eye is concerned, there's nothing much that you have to do about the astrocytoma. So now we move on to the last case for the day. We have discussed the retinal retinocytes. We have discussed the retinal astrocytes. We have discussed the retinal vascular lesions. And one vascular lesion is remaining for the quiz. And I've already given you a hint. And this is the retinal lymphocytes. So this is a case of a 60-year-old male who presents with a gradual decrease of vision. And he was diagnosed as uveitis, but he was unresponsive to steroids. And this is what we saw on clinical examination.
Lymphoma?
Yes, it is a lymphoma. Okay, so this is exactly very, very typical of a lymphoma. This is again called a leopard fur or a leopard spot appearance. These multiple creamy subretinal lesions usually coalesce in a ring fashion, or can be just like this in one quadrant. So a primary intraocular lymphoma is a subset of the cranial lymphoma. So you have malignant lymphoid cells, they involve the retina, vitreous or optic nerve with or without concomitant CNS involvement. So either your patient will have CNS lymphoma and about 20% of them will have intraocular lymphoma, or the patient can present with intraocular lymphoma and in about 2 years time, they go on about 60 to 80% of them in 2 years time, they go on to develop a CNS lymphoma as well. The median age of onset is 50 years to 60 years. And like I said, this is another patient who came to our clinic. You can see that the patient had these typical, so most common is actually a vitritis. So it can be isolated to the vitreous as well. So the most common finding on ocular examination is just a vitritis. And the findings would be just like a uveitis. The patient would complain of blurred vision, of floaters, of photophobia, of red eye, or like I said, he could have a decrease in vision and all that. And here, and floaters. So basically, the most common finding is vitritis. But on posterior segment examination, you can see the vitreous cells in clumps or sheets, or you can see these multifocal creamy subretinal infiltrates. How do you know subretinal? The OCT is here to help you. You can see the retina is elevated, and this is the RPE, and beneath the RPE, you have these dense infiltrates. This is passing through the lesion, and these are the characteristic subretinal infiltrates seen in the case of a lymphoma. And as we were waiting for a biopsy report, so we kept monitoring the patient. So in 2 weeks time, you see that these lesions have resolved. You see this characteristic RP atrophy, the corresponding autofluorescence because of the RP atrophy which has come up on the autofluorescence. And you can see this lesion has subsided on its own, and you can see that this lesion is now gradually enlarging. So this again, so that is what is typical of a lymphoma. You have large multifocal cream or yellow colored subretinal infiltrates, and retinal pigment epithelial atrophy and subretinal fibrosis can sometimes be seen on resolution, on spontaneous resolution. Okay, so this is a primary intraocular lymphoma. How do you establish a diagnosis? Now, establishing diagnosis in a case of primary intraocular lymphoma is a challenge. Why? Because there is, okay, so on the FFA, it basically shows absolutely no signs of inflammation. So in an eye, there are a lot of signs of inflammation, a patient complaining of floaters, there sometimes can be cells in the AC, but if you see there are a lot of cells in the vitreous, there is vitritis, but there's absolutely quiet on angiography. You have to think in terms of an intraocular lymphoma. There will be a characteristic lack of perivascular staining or leakage. There will be no macular edema and no other angiographic signs of evidence. So the eye will be hot, but the FA will be quiet. And that is what points towards an intraocular lymphoma. Definitely, you have to do an MRI study or a CSF study, a diagnostic vitrectomy to look at these lymphoma cells. They're basically B cell lymphomas. So you can do a histochemistry to look for B cell markers like a CD19, 20, or 22. And sometimes even a cytokine evaluation, that is an interleukin 10 to interleukin 6 ratio greater than 1 in either the aqueous or the vitreous fluid, can sometimes help in establishing the diagnosis. Now we have something known as a MYD88, which is a MYD88 gene, which can be detected on a PCR. If it is positive, is also suggestive of an intraocular lymphoma. So you can see these lymphomatous infiltrates here, and this is an intraocular lymphoma. How do you manage? Okay, basically, there are different schools of thought. Some say that the intraocular lymphoma is a part of the CNS lymphoma. So even if an intraocular lymphoma is detected, you treat it as a CNS lymphoma. The patient receives a methotrexate-based systemic chemotherapy. And in olden days, they used to give CNS radiotherapy as well. But now it's believed that CNS radiotherapy in elderlies is associated with a lot of morbidity, and patients sometimes develop memory loss and like retrograde amnesia. So now what they do, some school of thought is that they give a methotrexate-based systemic chemotherapy along with ocular radiation. If it is only for the eye, and if it's a recurrent disease, then they can consider an intravitreal methotrexate or a rituximab. So basically, chemotherapy, radiotherapy, and for recurrent disease is an intravitreal therapy. So what is the take home from this? The onset of bilateral posterior uveitis in patient over 50 years should be considered suggestive of large cell lymphoma, as should chronic uveitis in patients in their 5th to 7th decade. So I think that brings to the end of the presentation. I just have a few slides which are spotters, slightly difficult slides which are spotters. If you can sort of guess, it's okay. If not, also okay. But these are some lesions which make your eyes pop and wonder what they are.
This is the question, Anusha?
This is not the quiz question. This is just a spotter, which I've not covered, but it is a diagnosis of the melanocytic lesion. It is a little difficult one. It is actually called a B dump or a bilateral diffuse uveal melanocytic proliferation. If you see something like this, what you need to do is just refer the patient to an oncologist, because these are generally associated with visceral carcinomas. So with cervical or ovarian carcinomas, urogenital carcinomas in females, or with lung carcinomas in males. Sometimes even the uveal melanocytes can proliferate in response to that, and you can get something like this. So this is another spotter.
Racemose angioma.
Racemose angioma, also called
Weber-Mason.
Weber-Mason syndrome. Mason syndrome. All right. So these are the spotters, and I just have 3 quiz questions now.
Okay, Anusha, you can show the quiz questions and we'll give them around 10 seconds to answer in the chat box, and whoever answers first is the winner.
Okay. So the first question is is this. Which of the following about the following condition is false? Autosomal dominant, exudative and tractional retinal detachment may occur. Systemic screening is required with MRI brain, CT thorax, and urine examination is mandatory. Brachytherapy is effective for this condition. Which statement is false?
D.
Sorry?
You have to type in the chat box.
So after 10 seconds, I'll give you the answer.
Yeah, you can get the answer. There are so many responses already.
The answer is C. It is not CT thorax. It is actually CT abdomen. This is a case of a capillary hemangioblastoma or a retinal capillary hemangioma. It is autosomal dominant. Exudation can occur. Tractional retinal detachment can occur because of fibrosis. Brachytherapy is definitely effective for this condition. Like I said, for any vascular tumors, you can either treat it with laser, cryo, or periphery. If it is there, you can put a plaque and it will respond very nicely. The systemic screening is very, very important for retinal capillary angiomas, because these are associated with von Hippel-Lindau, and those are generally associated with pancreatic tumors or renal cell carcinomas. So it is not CT thorax, but actually a CT or an ultrasound abdomen. MRI brain, definitely for cerebellar hemangioblastoma. Urine examination, definitely for pheochromocytoma. So you have urine vinyl mandelic acid. It is not CT thorax, but CT abdomen.
Everybody answered D except Geesha Ravindran, who answered the correct C correctly.
Okay.
Geesha, where are you from?
Sir, I am a consultant in Vastan Eye Hospital, Trivandrum.
Oh, good one. Congratulations.
Okay.
Can you go to the next question?
Okay, so the next question is a relatively easy one. I've almost given the answer when I was talking about it. Which of the following statement about the condition is true? External beam radiotherapy is a treatment in most cases. Most children inherited the disease from an affected parent. These patients have high incidence of basically this case, okay, which I've shown here. Patients have high incidence of intracranial tumors. The average age of diagnosis is 3 years. Which of the statement is true?
Anusha, you can proceed with the answer.
The answer is C. Patients have high incidence of intracranial tumors. This is a patient with bilateral retinoblastoma. External beam therapy is no longer used, so it is not the treatment in most cases. Now, this is what I wanted to, again, I highlighted when I was talking about it. Most children inherit the disease from an affected parent. No, the presence of family history is only in about 7 to 10%. So if the child is affected, there's only a 7 to 10% chance that even the parent will be affected. So this is a false statement. They have high incidence of intracranial tumors because it's a bilateral retinoblastoma. Patient can have a pinealoblastomas. The average age of diagnosis is not 3 years. It's much younger because it's a bilateral. So we'll have germline mutation. So the average age of diagnosis will be about 12 to 24 months, which is about 1 to 2 years. So the correct answer is C.
Excellent. Darshana wins this one.
Excellent. Okay. And the last question is a very simple question. Which is the most common site, primary site for metastasis, for choroidal metastasis is in men? Lung, kidney, prostate, GI malignancy. Fastest fingers first.
Okay, a lot of answers.
The answer is A, the lung.
This will not be eligible as a quiz question. This was way too simple, no?
Yeah, I mean, you said 2 slides, so the third slide was a very simple question. So yeah, that's about it. That brings me to the end of my presentation. If you have any doubts, any queries, you can either ask me now or you're free to reach me anytime. Yeah,
Okay.
so that's about it.
Thank you, Anusha. This has been a wonderful Kaksha. It's a vast topic and it's impossible to cover everything, but it was a very well explained and a very comprehensive presentation. Thank you all the residents, ROS executive and teachers, and Anusha for the excellent teaching. We look forward to the next class in the coming weeks. Keep giving your feedback and suggestions for the Kaksha experience to improve, and do subscribe to the ROS official channel on YouTube. All the previous classes, including this, are uploaded there. Good night from Team ROS. Thank you, Anusha. Thank you so much.
Thank you. Thank you, Team ROS. Thank you, Vishal. And thank you, everybody.
Bye.
Bye-bye.